Hello, everyone. Welcome back to another session of our NCLEX review. And we are on day 49 of the 90-day free sessions that we're offering with Stancoast and NCLEXcoaching.com. And for those who are just new to the channel, you are welcome to be with us for the rest of the review sessions that we have. We still have a long ways to go. And we are also inviting you to enroll into our NCLEX program at our website. So kindly visit www.stancoastandclexcoaching.com and also check the description box below for more information. And we are going to tackle a variety of nursing topics and with a focus on med-surg for the meantime. But we'll be focusing on other topics in nursing as well. Also, we are updating the library that we have in our course. We have upgraded the number of hours for the animated videos and also the on-demand lectures. And we also have the 3,000 NCLEX style questions plus the 200 NGN test questions that would help boost your confidence. So I also encourage you to like, subscribe, and share this video with your friends who are preparing for the NCLEX. And also we are inviting you to put down your comments in the section so we'll know if you have any questions. If you need clarifications as well, please do so. And if you can tell us where you're coming from, and have a great evening, have a great morning, or good afternoon. Please like our channel. That's going to help us so much. And so if you are watching this review sessions for quite some time, and if you haven't liked the page, then I think it's time for you to do that. All right. Now, this time we're going to talk about the multiple sclerosis, which is a common disorder, especially in the young adult population. Okay. So this is going to be a chronic, it is considered as a progressive neurological disease, and it can affect the overall central nervous system, and we don't know exactly what the cause is, and it has unpredictable course as well. So please take note about MS. This is a progressive demyelination. So I want you to grab your attention in order for you to recall what the disease process is. This is basically the demyelination of the white matter of the brain. This is the specific description of the disorder. It affects more on the white matter. It will cause the demyelination. So I just want you to think about a regular charger, like for your phone, like your iPhone charger or the cord. And if you have probably used this cord for quite some time, then you will notice that the protective lining, that white plastic or rubber that is protecting the wires inside, could have been peeled off already. And this is quite similar to what is going on in multiple sclerosis. So basically, there is going to be the removal of the insulation, especially the nerve fibers, because of the, what do you call this, the formation of the lesions. It is causing damage, and it also disrupts the communication between the brain and also the rest of the body. And we're talking about the neurons. Now, the disease itself has exacerbations. It also has remission. So if we're talking about exacerbations, there will be periods wherein the person will have the flare-ups. And when we're talking about remissions, there will be periods wherein the patient will have some improvement in their overall state. They will probably have lesser manifestations throughout the illness. And with this disorder, it can affect mostly the young adults. And the range here is usually around 20 to 40 years old and mostly affecting women. Now, the reason why the body is attacking the nerve fiber, especially the white matter, the myelin sheath, this is caused by an autoimmune disturbance wherein the body or the immune system will now mistakenly attack the myelin sheath, and this is going to cause the formation of the lesions. Okay, so there will be lesion formation, or let's say plaques, and with that, it can lead to the disruption of the communication between the neurons. So looking into this photo right here, let's magnify this one. So we have our neuron. On the left side of the picture, you will see here that there is maybe a well-functioning neuron there. There is an integrity in the myelin sheath on the left side. However, when there is now damage or lesions or formation of plaques on the myelin sheath, especially the white matter, then it can disrupt the transmission of the communication between the neurons. So it can really lead to so many neurological symptoms, which we'll be delving in a minute. There are so many, so hang tight. Let's also talk about the primary effect on the white matter. So what is the white matter? Well, remember that the white matter is, it actually consists of the myelinated axons, which are actually the long projections of the nerve cells that can transmit the electrical signals quickly around the CNS. And also, the myelin sheath is produced by the cells called the oligodendrocytes, which will act as an insulation to those axons. And these are going to enable the rapid conduction of the nerve impulses. So let's take a look into the picture real quick to see where exactly that white matter. So, of course, those areas with that white color, they are the white matter areas. And of course, we have the gray matter, commonly in the cerebral cortex and also the basal ganglia. And we know that the gray matter, basically, it's going to consist about the neuronal cell bodies, or known as the dendrites, and also the unmyelinated axons. So what is the function really of the gray matter? Well, it is useful in the processing and also the regulation in sending the information within the central nervous system. And it can also play a vital role in the muscle control. That's just one. Another is sensory perception. It can also help with memory, emotions, decision making. And just to simplify things here, the overall effect of course, there's also gray matter and also the white matter in the spinal cord, right? So those areas where you see a darker spot, those are the gray matter sections of the spinal cord, and we also have the white matter in the spinal cord. Now, just to simplify things with the multiple sclerosis, this is basically a problem wherein the body's defense is wrongly targeting the protective coating of the nerve fibers in the brain and the spinal cord. And again, it will cause the formation of lesions, the plaques, and it can cause problems in the communication between the nerve cells. It could be in the brain, or it could be in the spinal cord, and maybe the rest of the body as well. So the symptoms here can come and go over time. All right. Now, let's talk about the causes of the multiple sclerosis. As I have mentioned already, that the exact cause is unknown. However, though, in researches, it is thought that it could be caused by the autoimmune dysfunction. Okay, so it's caused by a disease, an autoimmune disease, wherein the body's immune system will mistakenly attack its own tissues. So in a case of the multiple sclerosis, the immune system is again targeting the myelin sheath that is supposed to insulate the nerve fibers in the CNS. Again, I want you to think about that phone charger, that cord that is starting to peel off. And so the insulation is going to be removed, and this can now cause dysfunction in the sending of impulses from one neuron to the next. So if you have that phone charger, that cord that has already peeled off, maybe there's already breakdown of the small wires inside, then it cannot work as good as like a brand new cord for your phone charger. Okay. Now, let's talk about the susceptibility. For those who are new to the classroom, welcome back. And again, for those regular attendees, I appreciate your attendance always. I appreciate and I hope that you're learning as we go along with our review sessions. Now, let's talk about the susceptibility and the incidence of the MS. Again, I mentioned that it's going to occur more in women, and it's going to be about 2 to 3 times more than men. So it's not exclusive to women. It can also happen to men as well. Now, here, we're going to talk about the other possibilities. Let's say the contributing factors, it could be caused by certain infections that could trigger the multiple sclerosis, especially for the susceptible individuals. Or maybe for some instance, some studies actually suggest that there is a link between the multiple sclerosis and the Epstein-Barr virus. And again, the occurrence here will be more on the women, mostly affecting ages 20 to 30 or the young adults. Okay, so thank you, everyone. Thank you, James. Now, let's talk about classifying the multiple sclerosis. This is very important for you to know. Please don't neglect this. We need to classify the multiple sclerosis. And according to the National Multiple Sclerosis Advisory Committee, they have identified the 4 types of MS. So let's go right ahead and do that. So we will identify these 4 forms and their characteristics. So what are these? Well, the first one is what we call as the relapsing remitting type of multiple sclerosis, or known as the RRMS. Relapsing remitting multiple sclerosis. So around this type of form, which is basically the initial stage of the multiple sclerosis, the patient here, or the people with the relapsing remitting multiple sclerosis, have clearly defined flare-ups of symptoms. And these symptoms will develop over several days to weeks. And then we have had here that 2 to 4 weeks, right, of the development, especially in an acute attack. And then this is going to be followed by periods of partial recovery that can last for over weeks to months. But in average, though, the flare-ups can happen every 2 years, once every 2 years. That's the average flare-up. And around this time, there's no progression yet of the disease between the attacks. No progression yet. The person is set to be stable as far as the neurofunction between the episodes, and they don't really manifest a whole lot of symptoms this time. So probably they will end up ignoring. But if they are very keen in observing those subtle changes, then maybe they can get an earlier diagnosis. And most of the people with this kind of classification, the RRMR, or MS rather, it's about 90% of them, of all the total cases. And yeah, 90%. Now let's talk about the second classification here, which is basically the secondary progressive MS, or the SPMS. This is going to start usually as RRMS, or the relapsing. So it will start initially as the RR, but then it will shift, wherein the person will now experience more frequent relapses, and there's going to be steady worsening of their neurofunction, and even when not having an attack. And again, there is going to be steady deterioration of their neurofunction. And about 50% of those RRMS will transition into the SPMS. Again, 50% of those people under the RS or the RRMS, they will progress to the second classification within 10 years. All right. So it can progress eventually, and about 90% will progress within 25 years. So there is still a chance for those people in the relapsing remitting classification, they will lead into the secondary progressive. So there is no cure, guys. There is no known cure yet for the MS. The pharmacological treatment is only intended to slow down the progression of the disease. It's not intended to treat. There's no known medication that can treat MS. Again, it can only slow down. Now, let's talk about the third classification, which is the PP, or the primary progressive multiple sclerosis. And this is a classification wherein the person will have much more gradual worsening of their symptoms from the beginning. And they also have much more more symptoms from the beginning. And there is no clear relapses, no clear remissions in this type. Okay, now this is going to have the worst prognosis for disability, just to let you know right now. The worst prognosis for the disability. And this is a type of a classification that is more prevalent in men and also the older individuals. So please take note. This will occur more in men and older individuals. And the prognosis, again, is poorest in this kind of classification. Now, the fourth class here, which is the progressive relapsing, or the PR, this is quite similar to the PP, or the primary progressive, but it can include much more of occasional acute flare-ups. So, more of acute exacerbations, so they're going to experience some more of the signs and symptoms, which will really trouble them. And I'm not talking about mild symptoms here. We're talking about severe neurological manifestations that can affect their ADLs. They're going to be fall risk. Their ability to communicate will be affected. Their cognitive function is affected. Their memory is also affected. People will have significant memory loss, especially in the progressive relapsing type of MS. There's going to be dysfunction in their urination, their bowel and bladder control. That will eventually be impaired. And the patient here will go into several occasions of urinary tract infections because their bladder will now be kind of like neurogenic. It is somewhat flaccid. It is not going to be able to contract properly as we can. So the patient here will have occasional urinary tract infections because of the relaxation of the bladder. Their function of their bowel is also affected, and they're going to be prone to constipation. And there's some much more of manifestations that we'll be talking about. So again, guys, here are the 4 different classifications. So it starts usually with the relapsing remitting, and it will lead into secondary progressive. And during the late stage, the patient will be in the 4th classification, which basically is the progressive relapsing. Okay. And of course, the treatment here will vary as well, and according to the severity. All right, let's tackle our first question of the day. Question number 1. During a health history and physical exam of a 36-year-old woman potentially having multiple sclerosis, the nurse should A, check for chest pain, B, ask for about urinary issues, C, look for skin rashes or changes in color, or D, inquire about increased libido. Again, the test question said, during a health history and physical exam of a 36-year-old woman potentially having MS, the nurse should A, check for chest pain, B, ask about urinary issues, and C, look for skin rashes or changes in color, and D, inquire about increased libido. Take your pick. All right, I'm seeing B from Mary, ask about urinary issues. Let's try to eliminate the options. Let's try letter A this time. What's in letter A? Chest pain. What do you think about the chest pain? Well, this is not typically associated with MS. The MS It is a neurologic disorder. And so the clue here is the system, okay? The problem is in the CNS, okay? This is not associated to the MS, all right? The multiple sclerosis is primarily going to will affect the central nervous system, leading to neurological manifestations rather than cardiac issues. That's why we are eliminating this one. Not associated with MS. Like I've said, it will affect the central nervous system, and so it will lead to neurological symptoms and also problems in the nerve function in the peripheral parts of the body, right? But not about chest pain. Let's talk about letter D. Inquire about increased libido. What do you think about that one? Well, as we know that MS can also cause problems in the peripheral section parts of the body, it can lead to neurological symptoms and also a malfunction in the reproductive system. It can decrease libido, not increase. Decrease in libido. So this is wrong. Now let's take a look into letter C. Look for skin rashes or changes in the color. What do you think? Does it really affect directly into the skin or the integumentary system? Like rashes? Well, it is not really characteristic. The skin color will not be a characteristic symptom of MS. The discoloration, the skin rash, again, the MS can affect the nerve fibers that may lead to a wide range of neurological symptoms, but not affecting the skin in this manner. It will affect the skin when the person is no longer mobile. If they are bedridden, then they are prone to skin breakdown and wounds, but not rashes, not changes in the color of the skin, not necessarily. So we are going to have the last choice, which is ask about urinary issues. And I already mentioned that, right? In the first slide, we will be asking the patient about the urinary function because, again, the MS can affect the bowel and also the bladder function. The autonomic system will be affected. It can lead to so many issues, guys. So what are those? Urinary dysfunction, manifestation, urinary dysfunction, signs and symptoms. First, in no particular order, there will be urgency. There's also frequency. There's going to be incontinence. So this can happen towards the later stage. The person will not be able to really manage or control their bladder. There's also urinary retention. And this is the issue with the patient. They are going to develop recurrence of urinary tract infections. And the reason again here, it's because of the neurological damage affecting bladder control. So this is the option that you should ask to your patient. Do you have any issues with your bladder function? When you are taking the health history of the patient, ask about that kind of question. Or let's say ask about bowel control as well, because they will have the constipation as well. Okay? So our correct answer here is letter B. Don't worry, guys, if you are gonna commit so many errors today in answering the test questions. MS is not a joke. It is a huge monster that we need to eat and digest slowly. So we will do that today. Okay? The management is also complicated. It is complex. And if you're not familiar with this disorder, then it's time for you to get refamiliarized or familiar with this disorder. So let's talk about the clinical manifestations of the MS. Well, like I've said, it can affect so many parts in the central nervous system, and so many manifestations will be displayed by the patient. So the manifestations here really will depend on where the demyelination occurs. Okay, so the clinical manifestation is dependent on the location of demyelination. And again, affecting mostly the white matter. Okay, so let's talk about the early manifestation or the earliest manifestations in our patient. What would be that? Well, there will be transient sensory deficits. This is the earliest manifestation that the patient might encounter. And this might be a complaint that they probably would ignore, maybe because they have diabetes, and probably they would, oh yeah, maybe this is a complication of my chronic diabetes, and they will just, yeah, it's probably normal, and probably not think about the multiple sclerosis. And so again, this is the most common and earliest manifestation and could be easily ignored. Okay, so what are these sensory deficits that you will be investigating in our patient? Well, one of those will be the paresthesias. These are the tingling sensation, the pins and needles. Tingling sensation, pins and needles. These are very uncomfortable manifestations. And this will occur mostly in the face, arms, and legs. Face, arms, and legs. All right. So again, easily neglected, but again, this is going to be the earliest manifestation. Now, what else? There's going to be numbness. The person will probably report that they have partial or maybe incomplete, partial or complete rather. Partial or complete numbness. And this will typically start in one limb or one side of the face. Now, another manifestation is the impaired deep sensation. What is that? Whoops, let me clear that. Impaired deep sensation. What do you think about this one? Well, the patient will have a reduced ability to feel deep pressures or vibrations, and this can really cause them to be prone to skin breakdowns, right? And especially if they're probably walking barefoot in their household, they're really prone to injuries, especially cuts, and this can develop into wounds if not treated properly. Again, impaired deep sensation. They will not easily feel the deep pressure or vibrations, including vibrations. So they probably would be pressing their body part into a hard surface for quite a long time because they don't feel any pain or discomfort. And so this can really lead to so many skin breakdowns, especially that they have altered sensation. Now, another is that the patient will have this problem, which is also specific, impaired vibratory and position change. So the patient here will have difficulty in knowing the position of their limbs without even looking at them. And this can really predispose them into having injuries as well. They can fall because of the decrease in the sense of their position. Now, part of the early manifestations here is the visual disturbances, and this is caused by the optic neuritis, wherein the patient will experience pain with eye movement, and also they're gonna experience some diplopia, double vision, And at some point, there is also a temporary vision loss. And again, the reason for that is the optic neuritis. Remember about that cranial nerve? The optic nerve, which is that cranial nerve that will send impulses to the brain in order to interpret what the person is seeing. And so if there is optic neuritis, they're going to complain about temporary vision loss, pain with eye movement, diplopia. They're going to see two images on a single object. And also there's going to be a decrease in the pupillary reaction and also scotoma. So what is this scotoma? This is what we call as a blind spot. Scotoma. So they're going to see that black spot in the center of their vision. So this is what we call as scotoma, central scotoma. They're going to see that black spot or a blind spot in their center of the vision. Again, don't forget about the decreased pupillary reaction to the light. So you might see some sluggishness in the pupils when you are lighting them with a pen light. Sluggish reaction to light. Again, don't forget the visual disturbance. This is also in the early stage of the MS, optic neuritis, diplopia, scotoma, decreased pupillary response, and don't forget about the transient sensory deficits in the early phase. Paresthesia, numbness, there is impaired deep sensation and impaired vibratory and position change. So mostly, guys, what you will be recalling here would be more of sensation, vision and sensation. Don't forget about early manifestation. Vision, sensation, issues. All right, that's my clue. Now let's move forward into the general symptoms, and this can follow when the patient will have the initial manifestations. So what are the common general manifestations in a patient? Well, they're going to end up with fatigue and weakness. And fatigue is very common. It is debilitating. It can occur suddenly and may last for weeks without improvement. Okay? Occurs suddenly, and it is also debilitating. It may last for weeks without improvement. Okay? Now, the other one is weakness. This can affect mostly on the legs. Yeah, the person will have difficulty in walking, right? They're going to have difficulty in performing the ADLs. Difficulty walking. And also difficulty in doing ADLs. And I have a patient, a very young lady that I took care of. I only had one encounter because I was assigned to another patient. And so, yeah, she was very young, in her early 20s. She was very active, no known medical history. She was actually a coach in a gym. And what she was noticing was more about her inability to get more steady because she was a gymnast. And she noticed that she cannot really maintain the balance anymore. And so that really prompted her to seek help because of the decrease in her ability to maintain a balance. And of course, she is very active. And so, yeah, that was quite a change for her. It was devastating because she was only that young, right? And she was very active with her lifestyle. So she was not even thinking about anything about MS at all. And so, yeah, that was my experience with this patient. Yeah, I also dealt with an elderly patient, but yeah, that was quite of a different management as well. Now let's talk about the abnormal reflexes. The patient here with MS can also have hyperactive reflexes, or it could be exaggerated. Okay, either hyperactive or it could be absent. So maybe the patient here, when you're doing the patellar reflex, then their response will be reduced, or it could be spastic, wherein the muscles can contract uncontrollably, okay? Spasms in the muscles. So it could be hyperactive, wherein the deep tendon reflexes will be increased, maybe +4, or it could be either absent or decreased. So don't forget about the abnormal reflexes. Now, again, what's the reason why the reflexes are going to be dysfunctional? Again, the transmission of the nerve impulses from one neuron to the next is impaired because of the impairment in the what? There's no longer myelin that is able to protect those small wirings to help in the transmission of those impulses. Now let's talk about the visual disturbances. We talked about the early manifestations, right? But here, in the general symptoms, the visual issues will be much more pronounced, okay? This time, they're going to experience much more of the blurring of the vision in maybe one, or it could be both eyes this time. And this is caused by, again, the optic neuritis that preceded the issue. And aside from the blurring of the vision, there's also nystagmus, wherein there's gonna involuntary rhythmic movement of the eyes from one side to the other side, or maybe there will be circular eye movements as well. So that is what we call as the nystagmus. Now there's going to be motor dysfunction as well, and we're going to have to take note about the cerebellar involvement. Remember about the cerebellum that actually functions in the patient's balance, right? Coordination, balance. Think about the cerebellar dysfunction. So what can you think of here, especially if there is an effect into the cerebellar function, or let's say the motor dysfunction? Well, they are going to manifest those tremors. They're going to have involuntary shaking. All right. There's going to be involuntary shaking, and this can affect their coordination. They will also have trouble with their coordination. They will not be able to maintain those precise movements. They will become clumsy, and they will lack balance. So here, our patient will end up falling. Again, their gait, they will not be able to maintain that balance anymore. Yeah. Now, what else do you think can happen to our patient with the MS? Let's talk about their speech. Well, the person here will end up with slurring of the speech. They will be very difficult to understand due to the poor muscle control, aiding the speech. They will also have what we call as dysarthria, or scanning speech. So the person here will tend to speak very slow, and they tend to have more pauses. Speaks slowly and more pauses between the syllabus and also some words or phrases. Now let's talk about the autonomic involvement here, which is going to be a result of the upper motor neuron injury in the spinal cord. This is caused by upper motor neuron injury caused by the lesion, okay, in the spinal cord, of course. So what are those manifestations? Autonomic involvement. Well, as I have said earlier, the bowel control will be affected. This can lead to constipation. This can cause a reduction in the peristaltic movements, which is basically controlled by the autonomic nervous system, ANS. So again, if the affected part of the body is the spinal cord or demyelination of the spinal cord, this can affect their bowel control. Constipation is the sign. All right. Now, there's also impotence when there is lesion or lesions affecting the spinal cord, which can also affect the sexual arousal, or let's say it can cause erectile dysfunction. Then definitely this person will be complaining about it. Okay, impotence if there is an effect into the spinal cord. Another is the loss of the bladder control, which I mentioned in the first slide. This is also going to lead into the following manifestations that I enumerated earlier. We have hesitancy, frequency. They will be going to the bathroom back and forth so frequently because of the retention. There's going to be urgency, incontinence, and they will have recurrent urinary tract infections as well. Okay? It can affect the bladder function. Good morning, everyone. For those who just came in our classroom, welcome. Now, what else do we expect in this patient? There will be neurobehavioral manifestations as well. So what do you think? There will be depression. This is very common. It is going to affect the mental health in the patient. And it could be directly caused by the disease process itself, or maybe just the stress of living with a chronic illness. So either this is caused by the disease process, or could be the stress of having to live with a chronic illness. Because this is not going to be treated. It will only be, the progression will only be slowed down. Yeah. If they are very active in their life, they probably are athletes, but all of a sudden they will have this autoimmune disorder, which can really impair their lifestyle. It can definitely affect the overall state of our patient. Another is the cognitive impairment, which I mentioned earlier. The patient will end up with memory loss. There will be attention deficit, and also the loss of problem-solving skills. And so this will not be a person who should be designated in the decision-making, especially because this is going to be impaired. There's a lack of problem-solving skills in this patient. All right, there's also lability of their emotions. They can have outbursts of crying and laughter as well. Now let's talk about the late manifestations. There will be much more of severe motor dysfunction in this patient during the later stage. This is where things can be so heavy. Not talking about the weight of the patient, but the overall care that will be required for this patient. It can lead to the paralysis in severe cases, especially in the legs, and also the severe tremors and spasticity. They are going to have uncontrollable shaking. So this is going to be a predominant manifestation in this patient. Uncontrollable shaking. So we are going to manage this patient with those medications as well. There's also spasticity, stiffness of their muscles. And again, they're going to end up falling. They will not be able to do the ADLs because of these severe muscle spasms. They will not be as mobile. They will have, let's just say, disability. They cannot move around as normally as before. Now, talking about other problems in the later stage, they will have advanced cognitive decline. The memory loss here will be much more pronounced. They will have difficulty remembering recent events, not even information. And there's going to be much more of problem-solving disabilities. Their attention is much more reduced, and it can really interfere with their daily life and their independence. Now, another problem here is the chronic pain, and that is caused by the spasticity. So this is what we call as the neuropathic pain. So patients who have MS will also experience the neuropathic pain, which is severe. Okay, this can affect various parts of the body. This is a very common complaint in this MS patient. So why is this going to be a common problem? Well, this can manifest as hyperesthesia. Just restless and also painful. And they will also encounter what we call as the trigeminal neuralgia. Okay. Now, aside from the chronic pain, they're also going to suffer the speech difficulty and also swallowing problems. So during the later stage, our concern here will be more on their nutrition. They will end up with significant weight loss. And aside from that, if they have dysphagia, they will not be able to really contain oral secretions. They're going to be prone to choking, aspirations. So think about the complications just by the manifestation here. Aspiration leading to aspiration pneumonia as well. Yeah, a lot of issues. Nutrition, choking. Yeah. And other than that, there's also severe dysarthria, wherein they are not going to be easily understood because of the severe slurring in their speech. Dysarthria. Okay? Yeah, this is going to be a problem. Communication issue will be a problem in the later stage. Now, on top of that, we still have the bowel and bladder dysfunction, which will be more problematic around this time. There is going to be complete incontinence, right? Complete incontinence over the bladder and also the bowel movements. So this time, our patient care will also include frequent straight catheterizations because of the flaccid urinary bladder. Frequent urinary catheterizations because of the urinary retention. Catheterization. Okay, here we go. This MS is something else is affecting almost in the body. Can you please clarify that? Or can you please restate this MS is something else? What do you mean? Are there any more manifestations? Yeah, it's quite widespread, right? So I want to know exactly what the question is, AJ. All right, let me know. Just type in your message and I will answer. Okay? So let's talk about question number 2. For a client with multiple sclerosis, which risk should the nurse focus on? Select all that apply. Is it A, dehydration, B, falls, C, seizures, D, skin breakdown, E, fatigue? What do you think about this test item? For a client with multiple sclerosis, which risks should the nurse focus on? Select all that apply. A, dehydration, B, falls, C, seizures, D, skin breakdown, and E, fatigue. All right, while you are searching for the answer, I'm going to start rationalizing this time. Let me start with letter E, fatigue. Remember about the fatigue? It is one of the general manifestations. This is the most prevalent symptom. Most prevalent symptom, fatigue. So we are going to select that as a correct answer. It can impact their daily function and the quality of their life as well. So we really need to understand and make sure that we are managing the fatigue because this is crucial in the care of the patient. We want to make sure that we are optimizing their energy levels and also their activities. Now let's talk about letter D, skin breakdown. Well, as we have said earlier, because of the decrease in the mobility in the MS patient, especially during the later stage, this can also lead, or let's say the decrease in the sensation. Remember what I said earlier? Not just in the late stage, but also in the general manifestations. I mentioned about even the decrease in the sensation, even in the early manifestations, right? It can cause skin breakdown due to the mobility issues and also the sensation. Another correct answer because of the decreased sensation and also decreased mobility. Okay? If they are not able to sense a very hard surface, of course, this will cause pressure into that skin area. And if they're not able to position much more frequently as they should, it can lead to pressure ulcers. And the skin breakdown can also be related with the incontinence. Let's not forget that, okay? Incontinence, especially urinary incontinence. This can cause skin irritation, all right? If we are not really properly checking on our patient every now and then, if they are known to be incontinent, or we'll just probably, or maybe you're ignoring changing their attents or the sheets, this can cause their skin breakdown as well, okay? Now let's talk about letter C, seizures. What do you think about the seizures? Do you think about seizures as part of the MS? No, it doesn't, or it's not associated with MS. Not associated with MS. Remember about the seizures that we talked about yesterday? There are so many causes, right? The 4 M's and the 4 I's. Here, there's no outburst, abnormal outburst of the nerve impulses. There is none, okay? There is no irritability. What we have in MS is the poor conduction of the nerve impulses from one neuron to the next. There is delay in the conduction, right? So we are gonna mark this as wrong. Let's talk about letter B, false. Would false be part of the answer here? I know. False will be a significant risk for these people because of so many factors. Why they're going to end up falling. Again, muscle weakness is one of the reasons. There's also impaired balance. Remember about the cerebellar malfunction. Impaired balance and gait. Another is the sensory deficits. They will not be able to really feel those vibrations, their sense of position. That's part of it. Sensory deficits. Guys, do not ignore sensory deficits. Those numbness can actually cause a person to fall because they will have that diminished sense of position, the vibration as well. This can lead them to the frequent falls. Now let's talk about letter A, dehydration. Is dehydration a common manifestation in the MS? No, it is not highlighted as a typical association with MS. It is not. So we are marking this wrong. So our correct answers are letter B, letter D, and letter E. So what do you think can cause the dehydration? Well, the dehydration could be caused by maybe some other factors that could contribute. Maybe urinary dysfunction or maybe reduced mobility, which can lead to the dehydration if not managed properly, but it's not really associated as a manifestation of MS. It isn't so. We are only going to answer letters B, D, and E. So again, I am emphasizing about the muscle weakness. There's going to be the fatigue and the poor sensation, which can lead to skin issues. Again, the major issues in MS will be muscle weakness in this scenario, decreased sensation that can also please, incontinent, won't they reduce fluid intake that will cause dehydration? Well, guys, if you are talking about incontinence, it doesn't really mean that the patient is wasting too much fluid, right? Basically, the problem in incontinence is the inability for the body to control the passage of the urine. They will not be able to hold, or maybe they will not be able to control the passage of the urine. It's not about losing fluids. The fluids that we're talking about in the bladder is not caused by diuresis. No, there is no issue in the excretion, or let's say increased excretion of fluids from the body. There is no issue in that, okay? The issue here about incontinence is basically they're not going to be able to control the passage of urine because of the flaccidity of the muscle tone. It's no longer able to contract properly. Again, the issue is not about the diuresis. There's none. Another question: difficulty in swallowing. You said nutrition is a problem. Difficulty in swallowing. What do you mean? How about swallowing difficulties? Well, if we are going to talk about the dehydration here, it's not really going to be a direct causation. And if we are going to talk about the dysphagia, this will often going to happen into the more severe cases, but not on the general population of patients with the multiple sclerosis. Remember that it's not going to affect their nutrition during the earlier and also the middle stage. It's not. It's going to affect more into the later stage. I understand your points here, guys, about the dysphagia, but if we are going to have to look into the overall picture of the multiple sclerosis, this is not going to be a common or shared symptom in all cases, okay? It is not a common shared manifestation. Like I've said, it will be more on towards the later stage of the disease, okay? All right. But if you're talking about the nutrition, yeah, it will really impair their nutrition as well, but not specifically about the dehydration, okay? It will be, okay? Now, what else? How about swallowing difficulties? Swallowing, it will be a complication like the incontinence. All right, so it's not really the main symptom, but it can be a result to a preceding manifestation. So I hope that you understand the reasoning behind it. We cannot just generalize our patient with all the manifestations, again, because it can vary from one stage to the next. All right. Again, dehydration is not a direct manifestation on a patient, or the risk rather, okay? It is not really a direct risk to the person with MS, all right? Let's talk about number 3. In teaching a client with MS related bladder dysfunction about home bladder training, which instructions should be included? Select all that apply. Is it A, limit fluids to 100 mLs per day, or consume 400, 500 mLs of fluids with each meal? C, drink fluids mid-morning, mid-afternoon, and late afternoon. And D, try to avoid every 2 hours. Try to avoid rather. And E, use intermittent catheterization as necessary. So we're talking about MS-related bladder dysfunction about home bladder training. So which instruction should be included? Is it A, B, C, or D, or E? So what do you think? Thank you, Lynn. Appreciate it. It's a select all that apply. So what do you think? It's a select all that apply question, guys. Please don't forget it is SATA. So you were expected to answer just one option this time. Okay, let's try to answer or see if A is going to be eliminated here. Let's find out. Well, it said limit fluids to 1,000 mLs per day. This is restriction. Do you think that we need to restrict the intake of fluids? Not appropriate. Restriction of fluids in a patient with MS is not appropriate. And take a look into the root concern of our question here. The problem is about bladder dysfunction. Okay. So do we restrict their fluid intake? Of course not. Our patient will need adequate hydration. There is no reason that we need to restrict the fluid intake, because if we are limiting their intake, it can lead to dehydration. Yeah. And it is not going to be sufficient for maintaining the whole body function, right? And so again, we should not be restricting their fluid intake unless contraindicated, right? There's none. Eliminate that right away. What about B? Consume 400 to 500 mLs of fluids with each meal. What do you think about that? So again, we're talking about adequacy in the fluid intake with each meal. This will maintain hydration and also will support urinary flow. Okay, we're going to allow this one. It will maintain hydration and it will allow flushing of the renal system. So it can allow the patient to have much more consistency in their intake throughout the day, not just like during the morning or let's say afternoon. So make sure that we are kind of spreading out the water intake for this patient, or planning about their water intake throughout the day, which will be much more of a constant practice. It can help much more of bladder function effectively. So this will allow flushing of their renal system. So this will be one of our correct answers. Letter C, drink fluids mid-morning, mid-afternoon, and late mid-afternoon. Again, this is another correct answer. The person is going to be allowed to take in fluids at regular intervals throughout the day, and this is going to help manage their bladder function as well. Not just giving them the water during the morning and they will end up dried throughout the night. No, it will cause more complications in their patient. It will prevent urinary stasis. Prevents urinary stasis. I know there is a problem with the bladder dysfunction, but it doesn't mean that they are completely unable to urinate. They still can, but not able to completely empty. They will have dribbling, incontinence, but I didn't mean that they will not be able to put out urine. That's not true. They still can urinate. However, they will have much more retention. And this is something that we need to keep in mind. We need to do bladder training for this patient. All right, so answer is also letter C. Now, letter D, try to void every 2 hours. This is a good practice. Voiding at regular intervals, let's say every 2 hours, can help bladder over distension. It will reduce the risk of UTIs. Okay? Bladder training. It will promote much more of consistent bladder function in this person. Now, what about letter E? Use intermittent catheterization as necessary. If your patient cannot void, they are probably retaining significantly. For example, if the MS patient is complaining that, hey, I really want to pee right now. So you allow them to pee, right? So maybe they were able to put out a good 200 mLs. And you will ask the patient, hey, are you okay? Or did you feel like you emptied your bladder adequately? And if they say that, hey, I still feel full, I really don't feel like I've peed enough, I still feel something is in my bladder. So this time, we're going to have to check for a bladder distension, right? So if you are in the hospital setting, check for the bladder distension. We can do the bladder scanning. Have you used a bladder scanner in your rotation? Have you done this? Or at least observe a nurse doing the bladder scanning. Have you done this for post-voided residual urine? Post-voided residual urine. Have you done this? Let me ask you. If you have not, then you need to read about the checking of the bladder through the bladder scanning. So what we're going to do here is we're going to have to scan the patient's lower abdomen to check for abdominal distension. And if there is a significant retention, let's say greater than maybe 100, or let's say 110, that is a significant amount of urine already. So they are known to have urinary retention. So, or let's say if their urinary volume in the bladder and they cannot really expel it, or they cannot effectively void it, maybe 600, 500 after voiding, that is significant. So they need to be catheterized intermittently. We're going to do straight catheterization. Have you done straight catheterization to your patient? This is an invasive procedure similar to a two-way Foley catheter, but this is very temporary. You're only going to have to do this when the patient needs to be catheterized, and it will be taken out after the urine has been drained properly. Okay, so you're going to do the same aseptic technique, prepare, cleansing the meatus and everything, observing the same principles. Then you're going to have to do the straight catheterization and make sure that you're going to allow the urine to drain. The question is from AJ, does Crede maneuvers work? It works, but the problem with the Crede, if this is going to be done excessively, this can cause issues with the sphincter. Do not abuse the Crede method. You will only use this. It can work. It can work, but not effectively as compared to the urinary catheterization, especially during the later stage when there is severe bladder dysfunction. Then you really need to do the straight catheterization. All right. Again, the stages will have different severities. So it's not always like, hey, I can't pee right now. No. I mean, they will have much more significant urinary retention during the later stage, or let's say incontinence. It could be either. All right. It can work, but it depends on the severity of their MS. Let's talk about number 4. Which of the following is not a typical symptom of MS? Is it A, double vision, B, sudden energy burst, C, weakness in the limbs, D, muscle tremors? What do you think about that? Which of the following is not a typical symptom of multiple sclerosis? A, double vision, sudden energy burst, weakness in the limbs, D, muscle tremors. While you're looking for the answer, I'm going to start rationalizing this time. Let's talk about letter D, muscle tremors. We are being asked about not a typical symptom. So we are being asked to identify an assessment finding that is not a common manifestation in MS. Okay? So, muscle tremors. Remember that muscle tremors are common in a person with MS, and this is because of the damage in the nerve pathways caused by damage in the nerve pathways. And the patient will have the involuntary shaking, rhythmic movements of the muscles, and this is one of the manifestations. So we're not gonna answer this one, or we're not gonna pick this one, because this is a manifestation of MS. We are being asked about a symptom that is not typical. So we are eliminating that one. What about letter C? Weakness in the limbs. Remember about what I said earlier. The patient will end up falling because of what? Limb weakness. And this is a typical symptom. Not this one. Okay? So this is also an incorrect option. What about letter A? Double vision. What did I say earlier about the vision issue? Remember about the diplopia? Yeah. They have diplopia. And again, the problem here is because the MS can cause damage to the nerves controlling the eye movement. Damage to the nerve controlling the eye movement. And also the optic nerves. So we are eliminating letter A as well. It is a common manifestation in the multiple sclerosis. So we are eliminating that one. Remember about the diplopia, blurred vision? Yeah. And also the optic neuritis, the pain sensation during eye movement. Don't forget that. So take a look here. Sudden energy burst. Did we mention about sudden energy burst in MS? Nope. Never mentioned about sudden energy burst. It is actually the correct answer because this is not a typical symptom. Not a typical symptom. This is what we were being asked. Okay? Don't get confused. We are asked of a symptom that is not a common manifestation, which is this one. All right? Letter B. Again, in MS, what are you going to find in this patient? Not energy burst, but rather fatigue. Decreased energy levels. There is no burst of energy in MS. There is rather fatigue and also energy levels. Abby, it says home bladder training. I know, but patients can actually do their own self-catheterizations at home as well. They can. It is a common practice for patients to do their own self-catheterizations. All right, so just letting you know, in the home setting, they can do intermittent catheterization. All right. So if you're worried about option E being one of the answers, it's actually true. They can do self-cath at home. They can also do the voiding every 2 hours. And they can also do C and letter B. All right, let's move forward. Let's talk about number 5. A woman with MS asks about pregnancy risk. The nurse should respond A, MS symptoms might worsen post-pregnancy. B, premature labor is common in MS. And C, MS increases the risk of birth defects. And D, MS symptoms typically worsen during pregnancy. What do you know about pregnancy in MS? A woman asks about pregnancy risk. A woman with MS asks about pregnancy risk. The nurse should respond: A, MS symptoms might worsen post-pregnancy. B, premature labor is common in MS. C, MS increases the risk of birth defects. And D, MS symptoms typically worsen during pregnancy. Let's talk about letter D first. We'll see if this will be the answer. Letter D. MS symptoms typically worsen during pregnancy. Well, in contrast, rather, guys, the person with MS, especially the post-pregnancy period, the manifestations of MS this time will often improve or they will remain stable. Okay? Again, the symptoms of MS, let me write that down first. Symptoms of MS in pregnancy. They are actually going to be stable. They're not going to worsen during pregnancy for women. And the reason for that, what is the reason? Well, this is because of the related changes in the immune system that can occur during the pregnancy. Changes in the immune system during pregnancy, which will actually suppress the immune responses. Suppression of immune responses. Okay, so the level of the immune system activity during pregnancy is actually lesser this time, which will kind of like helpful for this patient in a pregnant state. So this is not expected during pregnancy. They will not have worsening. That is false. Okay, the reason for the stability in their manifestations during pregnancy, it's because of the changes in their immune system. There is suppression of the immune responses during the pregnancy period. That is why they will not have worsening. Okay. I'm not quite sure with the no there, Victoria. I'm not quite sure if you are opposing to the rationale that I'm giving. So let me know, please. Letter C. What is letter C? MS increases the risk of birth defects. What do you think about that? Well, according to the studies, there is no evidence of MS causing birth defects in the offspring. No evidence of birth defects in a pregnant multiple sclerosis patient. All right, we're marking that as a no as well. What about letter A? MS symptoms might worsen post-pregnancy. What do you think about letter A? MS symptoms might worsen post-pregnancy. Well, the reason that this is going to be a correct answer, it is because after the pregnancy, remember about the immune system function that is kind of lowered or changed during the pregnancy period. After the pregnancy, many of the women who here will have the increased risk of relapses, and there will be symptom exacerbation because of that change in their hormonal, not hormone, but the immune system this time will go back to its previous state. Okay, so again, during the postpartum period, especially the first few months after the delivery, this is the time when they're going to have much more of the relapse. Postpartum period, there's going to be relapse of MS symptoms. And again, this is caused by the return of the immune system function after the childbirth. So that is the correct answer, not letter B. This is also wrong. Premature labor is common in MS. It is not known. It does not increase the risk of premature labor. not known to increase premature labor. I hope that you got the explanation about why there is no worsening of the MS in pregnancy. It's because of their change in their immune system. There is suppression of the immune responses. And so they will manifest just similar to the pre-pregnant state. They have already the manifestation of the MS. There's no worsening at all because of the suppression of the immune system, which is an expected change during the pregnancy. All right. Did you get the rationale? Answer is letter A. Okay? I hope that you're learning from these different weird questions. I hope that you are learning, really, because these are very complex to understand sometimes. Let's talk about number 6. Situation calls for a client with MS shows severe tremors in the right hand during voluntary actions, spilling coffee and struggling to fasten a dress. The best legal documentation or nursing note for this patient is A, has an intention tremor of the right hand. B, right hand tremor worsens with purposeful acts. Or C, needs help with addressing. Again, C, needs help with dressing and eating due to severe tremors and clumsiness. And D, right hand tremor intensifies during buttoning clothes or drinking from a cup. So your patient with MS shows severe tremors in the right hand during voluntary actions. They're spilling coffee, struggling to fasten a dress. So how are you going to document this in your nurse's notes? Your nurse's note is a legal document, so you need to carefully describe what the patient is manifesting. What would be your accurate documentation? What would be the appropriate documentation that exactly reflects the act? What would be that documentation? It's stated here, severe tremors, the right hand, during voluntary action, spilling coffee, struggling to fasten a dress. Or we could have stated it differently. Yeah, I'm seeing people answering letter D, D as well, letter B. Okay. D. I'm seeing a shift of the answers here this time. Good. That's good. Let's tackle letter A. Has an intention tremor to the right hand. Will that specify or will that appropriately describe the action of the patient? This is vague and lacks specificity. Specificity. Vague, not specific. This is inadequate nursing documentation. Let's take a look on letter B. Right hand tremor worsens with purposeful acts. Does it really coincide with the overall scenario? Yeah, it can provide some information about the worsening of the tremors during the purposeful action, but it's not specific compared to the other option. Not specific. Okay. What about letter C? Needs help with dressing and eating due to severe tremors and clumsiness. What do you think about letter C? Well, what you're actually adding here is needs help, which is more of assistance. Is this really the reflection of the patient? You're actually thinking about the patient needing assistance, which is not really a direct description of what is going on. You are just assuming that the patient would need help. The statement itself is saying something about the need for assistance with dressing and eating, but it doesn't specify the different attributes, especially the tremors, and especially specific to the right hand. Okay, so we are not going to select this one. There is an assumption that the patient is needing help. That's not part of the overall picture that we are gathering here. Not accurate. However, if we're going to answer letter D, right hand tremor intensifies during buttoning clothes or drinking from a cup. Fastening a dress is considered as buttoning clothes. Okay? Drinking from a cup, there is spilling coffee. Okay? Of course, that will be much more of a precise documentation of this patient. Okay? There might be some synonyms that you need to really know of, but again, this is going to capture a better picture of what really is going on with your patient. So there was a question about AJ Ike earlier about giving more explanation to item number 5. MS symptoms might worsen post-pregnancy. Again, AJ, the reason why I said that letter A is the answer, because after the pregnancy, after the delivery of the baby, the function of the immune system will go back to its previous state. Upon the completion of the pregnancy, upon the delivery of the baby, the function of the immune system will go back to its previous state, wherein there is what? Hyperfunction of the immune system. It will now cause more damage into the nerve function. That's why they're going to have much more of the symptoms, because the disease process is not going to end. It will continue to affect those fibers, especially those neurons that are demyelinated. So this time, their manifestations will go back and will become worse once the pregnancy has ended. Okay? The immune system will go back to its former state, being so hyperactive, attacking the nervous system. So I hope that satisfies you. Let's talk about number 7. A client with multiple sclerosis is on baclofen, Lioresal. I hope that you're familiar with the drug. The nurse knows the medication is effective if it, A, induces sleep, B, increases appetite, C, relieves muscle spasticity, and D, lowers urine bacterial count. You're welcome. Number 7, a client with MS is on baclofen, Lioresal. The nurse knows the medication is effective if it, A, induces sleep, B, increases appetite, C, relieves muscle spasticity, and D, lowers urine bacterial count. Take your pick, guys. Lioresal, baclofen. Alrighty, I think that you're familiar with the baclofen. Good. That is the correct answer. Baclofen. Let's take a look into letter A. Induces sleep. Why do you think that this is going to be incorrect? Why incorrect? Let's go through. This medication is going to cause drowsiness. Can cause drowsiness. It can also lead to what? Other side effects, dizziness. But take a look into the question here. It said effective, meaning it is treating the main issue, which is basically the spasticity in our patient. Okay? The issue in our MS is spasticity of the muscles. And there is an explanation to that, okay? The treatment, which is the baclofen, will resolve or will allow the relaxation, or it can cause less spasticity of the muscles. So this is the therapeutic effect. We are being asked about therapeutic effect. It's not asking about the side effect. Letter A is a side effect. It can induce sedation. It can cause drowsiness. That is not the therapeutic effect. All right. So the main reason that the patient is taking baclofen is to treat the muscle spasticity. All right. That is why A is wrong. What about letter B? Increases appetite. Do you think that appetite increase is going to be an effective sign? Or, I mean, will it signify that the medication is effective for this patient? No. It doesn't have any effect on appetite. Baclofen does not influence appetite. Whoops. Okay. So we're going to disregard letter B. Let's talk about letter D. Lowers urinary bacterial count. Well, the medication is not an anti-infective. Baclofen does not have anti-infective properties. It is not an antibacterial. It's not any of those, okay? Anti-infective property. So it will not reduce any bacteria in the urine. It doesn't treat urinary tract infection. Does not treat, let me just shorten that for treatment, does not treat urinary tract infection. All right. So our correct answer here is to relieve muscle spasticity. That is the therapeutic effect of the baclofen. Now, let's know more about the medication. So what is really the drug classification of the baclofen? It is going to treat the spasticity. It can work in the spinal cord. It has that direct effect into the spinal cord. It will suppress the hyperactive reflexes that can cause the muscle spasticity. Okay? Again, the baclofen, it can suppress the hyperactive reflexes in the muscles by targeting the spinal cord. All right? In the literature, especially in pharmacology, it's not quite fully understood the exact mechanism, how it does that, but it has some kind of affinity. It has similar effect to any substance that can stimulate, or it can enhance the GABA as well, the gamma aminobutyric acid. It has a calming effect on the spinal nerves. Calming effect on the spinal nerves. Okay? There's more to know here, guys, because it's not really classified as a muscle relaxant. No, it isn't. Okay? It targets specifically the spinal cord, which will decrease the hyperactive reflexes. Now, that is the accurate drug action. This will help the patient of the discomfort from the spasms, and it can overall help them with their overall function as well. Now, the truth here about the baclofen is that it does not directly affect the skeletal muscle. Okay, I need you to understand this. This does not have a direct effect on the skeletal muscle. No direct effect. Unlike the dantrolene, which is another medication that can help the spasms, it's not similar to the dantrolene. It doesn't directly affect the skeletal muscle. What it does, it will help the spinal cord. It will target the spinal cord to decrease the hyperactive reflexes. It can also decrease the flexor and the extensor spasms because of the stimulation of the spinal cord. And it can be given in a PO route. It can peak in about 1 hour after the patient takes that medication. So baclofen can be given as a PO mostly. But have you noticed those patients that may have those baclofen implants in their abdomen? Have you seen those baclofen implants? I hope that you have seen those. And this is intended for the other patients that may have some chronic pain issues. They will have that kind of like similar to the insulin pump. They will have a pump that will be implanted under their skin to deliver accurate doses whenever they need to get their pain controlled. Okay, but it's commonly taken as an oral medication. It has an onset about 1 hour after it's taken by the patient. Okay, now let's talk about the excretion. It is going to be excreted in the urine. Okay, it is going to be allowed to exit the body in the urine only. Now, what are the adverse effects that you should be watching for this baclofen? There are many. Adverse effects will include the CNS depression, so be careful. Monitor your patients about their drowsiness, their dizziness, the weakness, and fatigue. Okay, so these are adverse effects. Now, let's also take note that they can manifest the adverse effects in the GI tract, which is nausea and vomiting. Aside from that, there's going to be constipation and dysuria, which is about 8% to 10% of all patient cases. Difficulty in urinating. That's an issue. Now, if the patient will probably discontinue the drug because they don't like to experience all these adverse reactions, adverse effects, they might just discontinue without notifying the doctor, right? Yeah, they can experience those withdrawal symptoms. And what are those withdrawal symptoms? They're going to encounter hallucinations, paranoid thoughts, and seizures. Again, this is a major issue. Seizure, especially when they are abruptly discontinuing their baclofen. Seizure. Hallucinations. They are not going to be able to follow whatever they're going to be told to do. They're confused. And what we're going to do here instead, when the patient is going to be probably, if there is a decision to titrate or let's say discontinue the medication, it has to involve the medical provider, make sure that they have that conversation, making sure that they're going to decrease the dose of the baclofen before completely discontinuing the drug, because we don't want those withdrawal manifestations. Okay, so make sure this is going to be stopped slowly. I mean, there will be tapering of the doses before it has to be completely discontinued. So I hope that you understand about the baclofen, guys. It is not really considered as a muscle relaxant, but what it is going to target the spinal cord in order to decrease hyperactive reflexes. All right, let's talk about the other medication here, which I just mentioned, dantrolene. It is another medication to treat the spasticity in our patient with MS. And I hope that you're familiar with the dantrolene. This is another drug that can directly relieve the muscle spasm. And so it has a direct action on the skeletal muscle. All right? It is going to do that. However, though, there are some more issues with the dantrolene compared to the baclofen. So we will tackle all that as well. It can reduce the muscle spasms. It can also reduce the contractility of the muscle. So our patient will end up with weakness. Okay. Now let's talk about the adverse or the route here. It can be given as a PO and has a peak onset about 1 to 2 hours, or peak rather. It will start to work better after 1 to 2 hours after they took that tablet. Okay. Now, where is the excretion? It can be excreted out of the body via the feces or the urine. And the adverse effects will constitute the following. There's going to be hepatic hepatotoxicity. So what do you think you should be doing here before you're going to start giving this medication to the patient? Since it can do hepatic toxicity, there should be baseline LFT evaluation. Check for the liver function test. If it is not ordered, talk with a medical provider. Do you mind ordering the LFTs before we start the therapy? Please do so. What else? Muscle weakness. Muscle weakness because it can cause a decrease in the contractility. So expect it that the patient will have muscle weakness. They can be high risk to developing falls, or they can be fall risk rather. All right. Now what else? They're gonna be drowsy as well. It has CNS depression type of effect. There's also gonna be diarrhea, difficulty swallowing, some hoarseness in their voice, and nausea, vomiting, and for men, erectile dysfunction. Okay, it can do that as well. Now, again, our focus here, especially if the patient will be treated for a long term, we need to have baseline LFTs and also regular LFT monitoring. The liver enzymes should be evaluated from time to time. Those AST and the ALT. Okay? All right. So, the hepatic toxicity is the main concern here in our dantrolene. They can also experience this flushing, which I forgot to put in here. Flushing of the skin. It can occur about 1/3 of the patients will manifest then. Not everyone, but it can occur to a certain number of people. All right. They will also manifest the flushing. Okie dokie. Now, let's talk about the other treatment for the spasticity, okay? There are so much more other options, but most of the time the medical provider will use the baclofen as the primary medication to help the spasms, and then the dantrolene, okay? But there are more medications. So other meds to treat spasticity. But I'm not going to elaborate because we have a long ways to go, guys. One is the gabapentin or the Neurontin. Another is the Lyrica or the pregabalin. In some cases, there might be a need to have botulinum toxin injections or the Botox. Okay, but this is not really widely used. There's also the use of the cannabinoid products. There's an evidence that actually the cannabinoids can have a muscle relaxing properties. Okay, especially that they're in a lot of pain because of the spasms. So these are alternative medications, and not the least though, but we also have physical therapy to prevent more spasms. This is very important. It has to be done together with the medical, or let's say it has to be done along with the pharmacological treatment. Stretching exercises will be needed in order to relieve the spasm. The patient will have to maintain flexibility of the muscles as well. That's why physical therapy is a huge part in the multiple sclerosis treatment. Okay. Yeah, it looks like Victoria is still answering those test questions in the previous items. Alrighty, let's talk about the question number 8. For an MS patient starting a bowel retraining program, which strategy is inappropriate? Is it A, high fiber diet, B, set regular times for elimination. C, use an elevated toilet seat. D, limit fluids to 1,000 mL per day. Before I go on, again, I am encouraging everyone to enroll in our NCLEX program. Our course is available for you to check out. So please drop by the Stancoast, nclexcoaching.com. You will be able to really get the benefits of our program. We have upgraded our the library of our on-demand videos for the lectures and also the animated videos. Plus, we also have the NGN test questions, the 3,000 NCLEX test questions, and we have some more resources for you. So kindly check the description box below. All right. Which strategy is inappropriate? Bowel training program. We're looking for an inappropriate intervention. Okay. Thank you, Victoria, for putting an indicator there. That would help. All right. So what do you think? You're answering B, D, D, D. Okay. So, which strategy is inappropriate? We are being asked to identify that nursing action that will not help the patient. That's what it says. So, if you answered letter A, high fiber diet, you are wrong. High fiber diet is going to be incorporated in our care plan because our patient is prone to what? Developing constipation. So what we are being asked here is inappropriate nursing strategy. Wrong. Okay. Letter B, set regular times for elimination. What do you think about that? Constant, regular schedule. We are also going to eliminate that because it is a good intervention. What we are asked here is about inappropriate nursing strategy. Eliminate that as well. What about use an elevated toilet seat? Do you think that this can become an inappropriate option? Elevated toilet seat. Remember about our patient with MS. Once they're going to have issues with their bowel function, take note about their muscle function as well. So, elevating the toilet seat for this patient can be very beneficial. It will promote proper positioning for them to have much more effective elimination. Okay, so this is a good nursing strategy. The bad nursing strategy that we're looking for here is letter D, limit intake, which is 1,000 mL per day. Bad nursing strategy, and that's what we are looking for in this test item. This is the correct answer. Yeah. Also for the hip, we don't really know the age, right? But again, with the decreased muscle strength in our patient in MS, yes, it can definitely affect their mobility as well, especially if the toilet seat is kind of on the low mode, like in a normal toilet seat. It will be difficult for them to use that. And so, yeah, this is one of the good, these are the good interventions. We're looking for the bad intervention. Letter D, limiting fluids to 1,000 mL can what? Can complicate to dehydration. Okay? Results to dehydration. Yeah, exactly. Remember what I said earlier, that even during the meal times, we're going to offer them about 400 to 500 mL, and it has to be spread out throughout the day to allow hydration, right? And it can also prevent the stasis of urine in the bladder. So we are going to pick this one because it is a bad nursing strategy. All righty, let's tackle number 9. For a patient with MS and urinary retention due to a flaccid bladder, the nurse should Hello, Catherine. Welcome back. Yeah, thank you. For a patient with MS and urinary retention due to flaccid bladder, the nurse should A. Decrease evening fluid intake. B. Teach the Crede method. C. Recommend nighttime incontinence. D. Assist to the commode every 2 hours. For a patient with MS and urinary retention due to a flaccid bladder, the nurse should A. Decrease evening fluid intake. B. Teach the Crede method. C. Recommend nighttime incontinence brief. And D. Assist to the commode every 2 hours. That kind of sounds over the top. What do you think would be the answer here? Retention. Flaccid bladder. We are talking about a muscle in the bladder that it's no longer functional. What would be that? Okay. Let's take a look on letter A. Decrease evening fluid intake. Decrease evening fluid intake. Well, we know already that restricting the fluid intake in the evening is not going to be appropriate for managing urinary retention because of the bladder flaccidity. Well, in fact, what we're going to need to do instead is we're going to have to maintain the overall health and prevent urinary tract infection. So we're not going to decrease that. All right? Wrong. Our goal here is to maintain overall health rather, and we are going to have to prevent the urinary tract infections. There's no need for us to decrease their fluid intake. Okay? There's none. What about letter B? Or letter D rather. Let me jump off to letter D. Assist to the commode every 2 hours. Yeah, it's somewhat kind of like, maybe this is the correct answer, right? It is a good intervention. Regular toileting is a good action. Regular toileting is actually good. However, our issue here is flaccid bladder. A flaccid bladder will not respond to regular toileting, despite the frequency in sitting on the toilet. The flaccid bladder will not respond to that. It will not address the issue. Okay? For those patients with a flaccid bladder, the problem here is impaired detrusor muscle. That is the muscle that actually causes the contraction in order to expel the urine from the bladder. That is the detrusor muscle. So despite if they're going to sit on the toilet probably several times, it will not. Okay? So what we're going to do instead is teach the patient to do the Crede method, especially that the problem here is about the flaccid bladder. Okay? We're going to do that. That's the best answer in this scenario. If there are some more options, I probably would not recommend the Crede, but here we are limited to what is only given in the question. All right. So in this test item, the Crede method should be taught for this patient, which is basically a gentle manual pressure over the bladder. Gentle manual pressure on the bladder. Do not overdo the pressure. Okay? So this is going to be helpful for those patients identified with a flaccid bladder because of the weakened detrusor muscle. So by applying this, if they're going to know how to apply the Crede method, this can help them empty their bladder. But again, do not let them do excessive pressure into the bladder, because if they're going to do that, that can impair also the sphincter control. Okay, so we want to make sure that they're just doing it right. All right, if you answered letter C, which is recommend nighttime incontinence briefs, it is just like a, what do you call this? It is only a temporary measure to manage the leakage. Only addresses the leakage. Not about the weak detrusor muscle. What we want to have is a relief of the flaccid bladder, urinary retention as well. And the best answer in this scenario is to teach Crede method, nothing else. Application of a gentle manual pressure over the bladder. Again, the briefs will not treat or will not, that will not address the urinary retention. It will only address the incontinence. All right, let's talk about number 10. A 33-year-old MS patient will start taking glatiramer acetate, or known as the Copaxone. What should the nurse include in teaching? Is it A, drink at least 4 liters of fluid daily? B, avoid driving or using heavy machinery? C, learn to self-administer injections? D, use non-oral contraceptives. The situation states a 33-year-old MS patient will start taking glatiramer acetate, known as the Copaxone. What should the nurse include in teaching? Is it A, drink at least 4 liters of fluid per day? B, avoid driving or using heavy machinery? C, learn to self-administer injections? And D, use non-oral contraceptives. Let's try to eliminate those erroneous answers. Let's tackle letter D. What is in letter D? The question asks, what should the nurse include in teaching? We'll start taking a brand new prescription. So what you should teach to your patient. Will D be a correct answer? Well, the Copaxone does not interact with oral contraceptives. Okay? Does not interact with oral contraceptives. And so if the patient is using the oral contraceptives to prevent pregnancy, then there is no issue. There's no need for them to use non-oral type because they can still safely use the oral contraceptives. Patient can still use oral contraceptives as prescribed to prevent pregnancy. Okay? There's no restriction, so there's no need for them to switch from oral to non-oral. That is wrong. What about letter A? Drink at least 4 liters of fluid per day. What do you think about that? Drink at least 4 liters of fluid per day. Well, according to the literature of the Copaxone, there is no requirement for increased fluid intake. Not required. There is no requirement to increase fluid intake when taking the Copaxone. So we are going to eliminate that one. At least 4 liters, that's a lot, but it's not required. So that's going to be eliminated. What about letter B? Avoid driving or using heavy machinery. What about that one? Avoid driving or using heavy machinery. Letter B. Well, according to the literature about Copaxone, it does not cause sedation. Does not cause sedation. So there is no concern about handling heavy machinery. No. Okay. So there is no influence as well in the motor function, as like we are talking about the Copaxone. So we are going to eliminate that as well. It will not influence. It will not cause sedation. It doesn't also impair motor function. So we're going to eliminate. But we have letter C, which is can it cause drowsiness? Is it known to cause drowsiness in the patient? It doesn't. It's not known to cause drowsiness, the Copaxone. No. The baclofen, yes, it can, but not the Copaxone. There's no need for us to observe this caution. However, letter C, learn to self-administer injections. This is going to be taught to the patient because our patient will be self-administering this at home. Okay, they need to learn about the proper injection technique. Requires proper injection techniques. Okay. Yeah, I see your point there, Abby. Teaching. Yeah, I see what you're trying to suggest here, teaching. But again, this will probably not be applicable to any kind of a scenario. Yeah, because actually you can teach any of these. Avoid, that's part of the teaching, education. And the main reason why we're gonna have to make sure that we are including this teaching, the proper or the self-injection, because the patient will be continuously be taking this medication at home. The patient will not stay in the hospital for the whole duration just for the injection. No, they can do this at home to treat their multiple sclerosis. Okay. And why about the proper injection techniques? Well, if they're not going to be able to properly observe the techniques, if they're going to repeatedly administer the medication to the same site, it can cause lipoatrophy. So it will be similar to the injection of an insulin. It can lead to lipoatrophy or lipodystrophy. And it can also cause irritation to the tissue, swelling, edema, pain. And so they need to really adhere to the teaching, the method, make sure that they are rotating and reporting those severe forms of reaction, especially with the injection. And we will be talking about this in the next slide. So our answer here is about letter C. Learn to self-administer injections. The rest, they're not going to target the question here. If you were going to ask me, are there any more better answers? Of course, there are better answers, but we are only limited to this situation with letter C. There are more, a lot. I want to share you with those interventions. So let's talk about the Copaxone, which is the glatiramer acetate. So what is this? This is a treatment that is known to cause modification of the disease process. That's why it's classified as disease-modifying therapy, or known as the DMT. This is very important, guys. So what is the Copaxone again? It is going to modify the disease process. It has a drug action specific to modulate the immune system. It will modulate the immune system. It will have that kind of, hey, just chill for now. I'm here. I will control you. The immune system will somewhat be in a controlled scenario. They're no longer hyperactive. Okay? Now, this is a medication that is going to be beneficial because of its anti-inflammatory effect, especially into the muscle tissues. Now, it also has it can be beneficial for the patient because it can be used for long-term therapy. Okay, long-term therapy. It is going to be administered 20 milligrams subcutaneously daily. If you're going to ask when is the medication going to start to work, it will vary. It can vary from several weeks to months. You will not expect an instantaneous effect of the medication. It will be a slow improvement, or let's say not really improvement, but slow disappearance of those manifestations. Okay, so here the medication as well, let me just erase this real quick because it's obstructing the view. The excretion of the medication is via the kidneys. So if your patient has an impaired renal function, this is something that you need to be cautious about. So your concern here is when the patient has renal impairment, because the excretion of the drug is through the kidneys. I cannot emphasize enough. Take note of your patient's renal function, creatinine, BUN, urinary output, because it is mainly excreted via the urine. Adverse effects, what do you think? It can cause local irritation, pain, redness, swelling, itching to the site. It can also cause the lipoatrophy. If there is continued use of the same location repeatedly, it will cause lipoatrophy. It simply means that the subcutaneous tissue will shrink. Okay? You need to teach the patient to properly rotate the injection sites in order to prevent that. That's your teaching. Teaching. Rotate injection sites. All right? That's very important. Now let's talk about immediate reactions. Let me erase this real quick. What are the immediate reactions when the patient will start the medication? They're going to possibly experience the following. There is going to be chest pain, palpitations, could be anxiety, shortness of breath, chest tightness. These are self-limiting, guys. Again, the immediate reactions such as chest pain, flushing, palpitations, anxiety, shortness of breath, chest tightness, they are self-limiting. You have to monitor the patient. Do not neglect, do not ignore, do not anything invasive, okay? Observe the patient. However, if the patient will have a different reaction, let's say anaphylaxis, well, how are you going to differentiate anaphylaxis to immediate reactions? In anaphylaxis, there will be widespread hives. There's going to be severe hypotension because of what? The dilation of the blood vessels. That separates the anaphylaxis to the other response. Okay? So there's going to be significant hypotension, respiratory compromise. This time, you're going to be ready with administering the epinephrine. Okay? So be careful in deciphering which one is much more severe. Is this anaphylaxis or is it not? So you need to observe the scenario in the test question. Now let's talk about, oops, not yet. I'm not quite ready to ask you. Let's talk about the Copaxone. This is a medication that is basically going to be, again, used for long-term use, and it can modulate the immune system. It will have that anti-inflammatory effect. It will delay progression. Delays progression of MS. That's the reason why it is going to be useful in this patient. Delays progression in the MS manifestation. All right. So we're going to have two injection redness. Yeah, let's tackle here about the skin issues, especially with the irritation. What are we going to do there, guys? We need to address that. So if the patient will be complaining of the swelling, itching, redness, and when they are having this problem at home, then what we can do is to teach them about the care. So what are we going to do? We're going to have to teach them about cold application to the site. Cold application. So I'm talking about the side effects here, or the adverse effects rather. Whoops, adverse effects. Cold application to the site, and this is going to be alternated with the warm compress as well. Okay. And if it's going to involve itching, antihistamines, over-the-counter antihistamines can also help. All right. So the patient will be treating this symptomatically, and it can also reduce the swelling and the redness. And make sure that you teach them to avoid rubbing the site. Avoid rubbing the injection site. All right. Now for the itching, if the antihistamines will not work for that, then maybe they need to have a prescription, a corticosteroid creams. That is going to be, not really. Not every corticosteroid will need prescription. There is an over-the-counter corticosteroid that will be helpful in treating the itching as well. Okay. All right. Now, I just want you to decipher here, if the patient will have the anaphylactic reaction, this is the time that you're going to have to get ready with the administration with epinephrine. If this is going to happen in the home setting, then they need to call the 911 in order for them to have immediate medical attention. If in case they don't have the epinephrine at home, they need to see the doctor in the ER, okay, or it could be the urgent care as well. All right, let's move forward. Number 11, for a client with MS and impaired peripheral sensation, which instructions should be included in discharge planning? Select all that apply. For a client with MS and impaired peripheral sensation, which instructions should be included in discharge planning? Select all that apply. Is it A, test bath water temperature carefully? B, avoid kitchen activities to prevent injury? C, do not use hot water bottles or heating pads? D, check skin daily for injuries or pressure points? E, wear warm clothes outside in cold weather. So your patient here with MS has impaired peripheral sensation. So you're asked right now to what instructions you should give to your patient during the discharge plan. Is it A, is it B, C, D, or E? What do you think? All right, while you are searching for the answer, I will start eliminating them. Let me start with letter E. Wear warm clothes outside in cold weather. How about that? Would that be appropriate? Wear warm clothes outside in cold weather? Remember about the decreased sensation in MS? Yeah. This is a major issue in MS. They will have decreased sensation ability. So if our patient is not going to cover themselves properly in a cold weather outside, this can cause cold-related injuries. Can cause injuries. What are those injuries? It could be frostbite. Yeah, no kidding. Yeah, it can cause frostbite. So we are going to instruct our patient to make sure that they are properly wearing the right amount of clothing, layers, insulated garments, in order that they can regulate the temperature and also prevent the cold exposure. This is a good discharge plan. All right, what about letter D? Check skin daily for injuries or pressure points. What do you think about letter D? Well, as we know earlier that there is decreased sensation, there's also decreased mobility, muscle strength. They are going to be prone in developing those injuries, especially pressure ulcers, right? Yeah, this is quite related to letter E as well. Risk of pressure ulcer is high in this patient. So we need to do this skin check daily for injuries and pressure points. Yeah, they have impaired sensation, as we have mentioned earlier. And make sure that the inspection will be regular in order for us to in order for the patient to report to the medical provider if they're developing any pressure sores, and if there's any cuts, that needs to be treated right away. So this is also a good intervention. What about letter C? Do not use hot water bottles or heating pads. What do you think about that? Yeah, of course. They have altered sensation, so avoiding or do not use hot water bottles instruction will be very important. This is also correct. Now this time, avoid kitchen activities to prevent injuries. It said, avoid kitchen activities. How will the patient be able to navigate around their kitchen if we're going to implement this? Avoid kitchen activities. This is too restrictive. Too restrictive. You're like a Nazi for this patient. Do not do that. Avoid kitchen activities? That is false. There's still more stuff that they can do not involving heat, right? Yeah, it's too restrictive. Completely restricting their kitchen activities will limit their independence as well and their quality of life. So instead, they need to do some more protection. You need to teach them adaptive techniques. Teach adaptive techniques, not avoid kitchen activities. So what are you going to include here? Teach adaptive techniques in the kitchen. They need to use mitts, especially if they like to bake, oven mitts, protective gloves. Okay, that's another one. And the safe use of the appliance with safety features. This can also mitigate the fear of having an injury. So we're not gonna, yeah, he will not be able to eat if she's not able to navigate around the kitchen. What we need to do is teach those adaptive techniques so they can proceed with their independent lives. They need to be cautious. They need to be taught how to properly manage around the kitchen. All right, let's take a look at letter A. Test bath water temperature carefully. What do you think about that? It is also correct. Even though that they have impaired peripheral sensation or sensing hot water, this can also be done through the use of the thermometer, not just their hand or fingertips. Testing bath water temperature carefully with the use of a thermometer. Yeah, there's thermometer. It's available. So why not use it? So our answers here are what? We have letter A. We have letter C. We also have letter D and letter E. Guys, this is a common question that can appear in the NCLEX. These are all risk reduction techniques. Yeah. So don't neglect these type of questions because they would test you on how knowledgeable you are with teaching your patient those appropriate teaching knowledge, or let's say techniques. So don't ignore this. Number 12, to help a client with MS avoid urinary incontinence episode, the nurse should suggest A, limit fluids to 1,000 ml per day. There we go again. We're back to that 1,000 mLs. Letter B, insert an indwelling urinary cath. C, establish a regular voiding schedule. D, use prophylactic antibiotics as prescribed. So here our question is asking techniques or interventions to avoid urinary incontinence episode. Okay. It's not giving us any information about flaccidity of the bladder. Not this time. We don't have that information. So don't carry over what you had in the previous test question. We are limited to what is in our screen right now. All right. Let's take on letter A. Limit fluids to 1,000 ml per day. 1,000 ml per day. That's too much of a restriction, guys. This can cause dehydration. Yeah, it can cause dehydration. What else? It can also make the concentration of the blood way too high. It could possibly cause hypernatremia because of the less fluid content in the body. Dehydration, hypernatremia might set in. This is a wrong action. Let's take a look on letter B. Insert an indwelling urinary catheter. Did we mention about indwelling urinary catheter earlier for incontinent episodes? No, we are not gonna use the indwelling catheters for this type of issue. It will. Indwelling, this is different, guys. Indwelling urinary catheter. This will stay a lot longer in our patient's bladder. The balloon, the tip, it will stay a lot longer. The patient will be predisposed to developing urinary tract infection. And the question is about incontinence. All right, let's tackle letter C. Establish a regular voiding schedule. Yeah, the schedule should be established with the patient. It is an effective, it is a non-invasive strategy that will help manage their urinary incontinence. Okay, we're gonna select letter C this time. It will train their bladder. Hey, I'm going to the bathroom right now. There's that brain to the bladder communication that it's time to pee. I'm reminding the bladder right now to go ahead and pee. Yeah, it can do that. It can maintain the bladder function and also maintain control over. Maintains control of urinary symptoms. All right. What about letter D? Use prophylactic antibiotics as prescribed. There's no indication to do prophylactic antibiotics. There is none. Incontinent episodes. This is not going to prevent the urinary incontinence in MS. The antibiotics will only be used if there is going to be a urinary tract infection. Only used. Let me just put it right here. Antibiotics only used when there is active infection. Okay, there's no indication that we should be administering or teaching them to use prophylactic antibiotics. No, that's never been a practice. And there's no evidence that it can prevent urinary tract infections either. Okay? We're going to select letter C as a more effective means in managing their incontinence. Because the incontinence can occur if, let's say, if the patient is not trained to do the regular schedule. Let's say the patient probably would just sit on their couch or bed for the entire 6 hours during the daytime. So around that, if their urine is not emptied in that given amount of time, it can cause overflow incontinence. So all the more, it can worsen the urinary incontinence. So having a regular voiding schedule can decrease overflow incontinence for this patient. Let's move on to number 13. Okay. What specific details regarding a 60-year-old patient with MS indicate the need to consult the healthcare provider before administering dalfampyridine Ampera? Have you heard about this medication, guys? Maybe, maybe not. The question states, what specific details regarding a 60-year-old patient with MS indicate the need to consult the healthcare provider before administering dalfampyridine Ampera? Is it A, walks a mile daily for exercise, B, complains of neck pain, C, increased serum creatinine level, and D, has relapsing remitting multiple sclerosis? Okay, what do you think is the answer here? Ampera. Let's try to eliminate some of the answers. Let's start with letter A. Walks a mile daily for exercise. Yeah, it's very important that we are promoting ambulation, walking, but it doesn't impact the administration of the dalfampyridine. It's not specifically, the medication itself does not specifically indicate improvement of walking or speed. So it's not going to be associated. No benefit at all. Okay? This does not impact administration of the medication. Does not impact administration of Ampera. What about letter B? Complaints of neck pain. With this medication, it's not also a specific concern. Okay? Not a concern. So we're also eliminating that. What about letter D? Has relapsing remitting multiple sclerosis. Letter D. Well, the relapsing remitting MS is not a contraindication for the medication use. So, the question here, let's go back to the question. Indicate the need to consult the medical provider before administering. So basically in this scenario, you will think of, hey, should I consult first, or should I have some doubts about this order if I observe this kind of scenario in this patient? So you will have second thoughts for the administration of the medication if you are going to capture any of the following options. So D will not be a contraindication. Not a contraindication, because the medication will treat the relapsing remitting multiple sclerosis. So our answer here is letter C, increased serum creatinine level. Why? Because the medication is known to cause renal impairment. Okay? Before we are going to initiate the medication to this patient, we need to assess kidney function first. It's a priority. We need to take a look into the creatinine, the BUN, creatinine clearance, could be the EGFR. That would be better, right? If the patient has impaired renal function, this patient might end up with toxic levels of the AMPERA. If there is impairment in kidney function, it can lead to toxic AMPERA. AMPERA, toxic drug levels of the AMPERA. All right. The only site of excretion of the medication is through the kidneys, so we want to make sure that the renal function is checked first. Toxic drug level. So our correct answer here is letter C. Okie dokie. Let's move forward to number 14. Let's take a look. The nurse educates a newly diagnosed multiple sclerosis patient about medications for the condition. Which response from the patient suggests a need for additional teaching? The question states, the nurse educates a newly diagnosed multiple sclerosis patient about medications for the condition. Which response from the patient suggests a need for additional teaching? Again, guys, we are encouraging you to enroll to our NCLEX program course at our website. Please check our website. The information is there regarding the subscription and the price. So please do that. And also check on the description box below. We have more information about our offerings as well. So please do that. Okay. Now, what are the options here? Option A stated, I might need extra drugs during relapses. B, I will need medication indefinitely. C, starting medication early can lead to permanent remission. D, some symptoms can be managed with non-drug approaches. Go back to the stem of the question, which is basically capturing that response that suggests need for additional teaching. You're going to identify that statement that did not reflect understanding about the treatment. So what is that option? Will that be letter A? Will that be letter B? Letter C? Letter D? Remember, guys, about the treatment, there is no cure in MS. Remember that concept. There is no cure. No cure, guys. There is no cure. I hope that you are catching the clue. There is no cure in MS. With the medications that we have mentioned, there's more to follow here. There is no cure. So let's start to eliminate. Let's start with letter A. I like to do that, letter A. I might need extra drugs during relapses. Yes. During the relapse of the MS, they're gonna require additional medications to address the symptoms. This is a statement that is actually showing understanding. I might need extra drugs during relapses. I will let you know later. There's going to be administration of the IV steroids plus the disease modifying medications, disease modifying therapies can be added or can be also used on top of the IV steroids. So they're going to need more medications during that time. So with that statement, I might need extra drugs. That is correct. The patient will definitely require more medications to treat the relapse. There will be exacerbation of the manifestations. They're going to need a lot of drugs, therapeutic drugs, not drugs out in the black market. Letter B, I will need medication indefinitely. Indefinitely? How is that true? Indefinitely. We know that the multiple sclerosis is a chronic condition, right? It will require lifelong management with medications in order for them to control the symptoms and also to prevent the relapse, and also the disease progression will be slowed down. And so when the patient will be stating, I will need medication indefinitely, this is reflecting understanding because the patient will be using those drugs long term. Okay. Long-term use of medications. So they will have that indefinite taking of the medication. So this is also a correct statement. It's not what we are looking for. We are looking for the wrong statement. So XX. What about letter D? Some symptoms can be managed with non-drug approaches. Do you think D is correct? Yeah, some symptoms can be managed with non-drug approaches, which is exactly correct. Those approaches, such as physical therapy, also occupational therapy, there's lifestyle modifications. My handwriting. Lifestyle modification is another one. Modification. They are going to be important in managing the symptoms of multiple sclerosis. It will also help improve their lifestyle, the quality of life. So, if you had answered starting the medication early can lead to permanent remission, was there any fact about permanent remission? The medications that we had mentioned will not treat the patient. Will not cure. There is no cure at all. So the statement saying permanent remission is false, even during early detection, early diagnosis, early therapy. It will not lead to permanent remission. It will only slow down the progression of the MS. Slows down MS progression. I hope that you're learning from this different ins and outs of the treatment. I hope that you are. Let's talk about number 15. A patient has had MS for a decade with 3 episodes of neurological issues lasting several weeks, followed by long recovery periods. In the past 6 months, the patient has experienced persistent neurological problems without improvement. Which subtype of MS might this patient have? The question states, a patient has had MS for a decade with 3 episodes of neurological issues lasting several weeks, followed by long recovery periods. In the past 6 months, the patient has experienced persistent neurological problems without improvement. Which subtype of MS might this patient have? Is it A, primary progressive MS, B, progressive relapsing MS, C, relapsing remitting MS, or D, secondary progressive MS? Your answer, please. Okay, while waiting for your answer, I'll start rationalizing. Let me have letter A, primary progressive MS. Remember that in primary or PP, remember that this is going to be characterized by more of a steady progression. There is steady progression in primary progressive. And we're talking about neuro signs and symptoms. Okay? There is no relapse periods or remission. No relapse, no remission. It's just steady. It goes on steadily. So if we are talking about the scenario here, in the past 6 months, it stated, oh, hang on a sec. A patient has had MS for a decade with 3 episodes of neurological issues lasting several weeks. However, it is followed by long recovery periods. The long recovery periods is actually the remission. So it doesn't fit to this letter A. This is incorrect. There is remission in the scenario. Okay? Now let's talk about letter B, progressive relapsing MS. What do you think about the progressive relapsing? Remember that the PR, it is going to involve steady worsening. Steady worsening of signs and symptoms from the onset. So there will be occasional acute relapses. Acute, occasional relapses. Okay? And so in the question here, the patient had distinct relapse episode followed by periods of recovery earlier in the disease course. And so basically it's not gonna match with the scenario. It isn't. Steady worsening. It isn't. So we are gonna eliminate this one as well. Let's take on letter C. Relapsing remitting. What is in relapsing remitting? It is going to be distinguished as what? Distinct relapses or exacerbation. Relapses, exacerbations of neurological symptom, and there is also partial or complete recovery periods. Partial or complete recovery periods. Now, look into the scenario. Well, in the scenario, the patient has current presentation of the persistent neurological symptoms. Take a look in here. In the past 6 months, the patient has experienced persistent neurological problems without improvement. And so this is not really going to fit letter C as well, because again, the letter C will have relapses, exacerbation. It will also go through a partial complete recovery over 6 months. And so there is basically a transition beyond the typical relapsing remitting phase. So this is also incorrect. So we have our last correct answer, which is secondary progressive MS. So what is this? This is basically going to follow the secondary progressive MS. It can follow initial relapsing. Follows initial relapsing remitting course. And the patient will also have distinct relapses, and then there are going to be some remission. And over time, the disease process will transition to a progressive phase, which is basically this one right now. In the past 6 months, the patient has experienced persistent neurological problems without improvement. This is the description we're in. The patient will now transition to a more progressive phase. There is continuous worsening of the manifestations with or without superimposed relapses. So this is going to fit the exact scenario. This is letter T. Do we have anybody who answered letter D? I think we have James. Okay, not bad. So go back into the description of our classification. And I'm going to be doing this last question right now. I actually prepared so many, but we'll be ending this question. This will be our last question. A patient diagnosed with primary progressive multiple sclerosis for 1 year mentions a recent short period without symptoms. The nurse will explain to the patient that this indicates what? A, potential for extended period without symptoms. B, brief period of improvement. C, onset of relapsing remitting multiple sclerosis. And D, transition to secondary progressive multiple sclerosis. It stated a patient diagnosed with primary progressive multiple sclerosis for 1 year mentions a recent short period without symptoms. The nurse will explain to the patient that this indicates what? Is it A, is it B, C, or D? Progressive multiple sclerosis for 1 year with a short period, recent short period without symptoms. Short period without symptoms. So what would that be? Is it A, potential for extended period without symptoms? Remember that we're talking about a primary progressive multiple sclerosis. Okay, remember that the PP, it is characterized by steady progression of the disability without distinct relapse or period of remission. Okay, remember that P, there is what? Steady progression of disability. No distinct relapse or periods of remission. No relapse or remission. This is wrong. Extended period without symptoms, that is wrong. Let's take a look into letter B, brief period of improvement. What do you think about brief period improvement? As we are going to review the primary progressive multiple sclerosis, that in itself, in a primary progressive period, the patient basically will experience a gradual worsening of the neurofunction without remission periods. However, an occasional brief period, that's totally different from remission. If there is a brief period of stability, or let's say a brief period of improvement, then they are not sustained or indicative of a long-term remission. It's not remission. It doesn't constitute remission. So this is basically the correct answer. Brief period of improvement. It doesn't constitute remission. A short time, that is the correct answer. If you had answered letter D, transition to secondary progressive MS, that is also incorrect, because as we know that the secondary progressive MS, it follows initial relapsing remitting course, wherein the patient will have, they may later experience a gradual worsening of symptoms without distinct relapses. And in letter D, it doesn't develop directly from the primary MS. It doesn't. It has a primary progressive course from the onset of without remissions instead. So this is also incorrect. What about letter C? Onset of relapsing remitting MS. Relapsing remitting MS. Remember that it is also characterized by what? Distinct relapses, which is going to be followed by a partial or complete recovery periods between the episodes. And it doesn't really fit into this short period, because in the relapsing remitting, it has that complete recovery between episodes. So it doesn't fit. So we only have letter B, brief period of improvement. Okay, guys. So I'm sorry I have to end the session this time. It's already late in Eastern time as requested. Yeah, I really encourage you to review more about the MS. If you are not quite familiar with the disease process, there's a lot more to know about the treatment. Again, there's a lot. So I thank you for your time in attending the session. I hope that I'll see you again tomorrow at same time at 9 p.m. And I always encourage you to subscribe this video, like our channel, and also share this to your friends. And make sure that you also enroll to our NCLEX course that will be good for 6 months. And if you really need to know the price, go into the website so you will know more about us. Okay? We have updated our hours in the recorded videos, the on-demand videos, and also the animated videos, plus the 200 NGN test questions, and also the 3,000 NCLEX test questions on top of those other offerings. So I thank you for your time again. I hope that you had learned something today that you probably would not forget. So again, you are welcome to come back to listen or watch to our video again tomorrow. Please do so. Again, thank you and have a great night, good morning, have a great afternoon, wherever you are. You take care, guys. Bye-bye.